Good afternoon, and welcome to the Alliance for Health Policy's Health Equity Summit. We have known for decades about disparities in health access, quality, and outcomes that disproportionately prevent all who live in our great nation from living their longest, healthiest life possible. But the COVID pandemic and attention to the historical and present-day legacy of racial injustice in our society have brought health equity top of mind for the health policy community and have led us at the Alliance to redouble our commitment to bringing fact-based and solution-focused dialogue on health equity to our nonpartisan educational programming on health policy. So we at the Alliance thought this was the right time to take stock of the conversation on health equity in America, reflect on lessons learned from the pandemic, and apply an equity lens to the future of health beyond COVID. We will examine policies, practices, and other factors in place now and from times past that are perpetuating existing health inequities or have left a legacy of inequities. We'll learn about the organizations, communities, and individuals who are making promising steps to build equity in our healthcare systems, communities, and homes. And most importantly, we will seek to better understand together how we can improve health outcomes for all. Our speakers will identify tangible action items and health policy options to start advancing health equity where we are right now and into the future. Some of you in attendance have been researching and writing eloquently about health equity throughout your careers. Some have lived experiences and insights on the sustained inequities in our healthcare system, and others might be taking your first earnest steps towards better understanding health equity in your work, or simply be curious about what this dialogue will bring. Wherever you are in your learning on health equity, welcome. This is a space where you can get your questions answered and perhaps discover new approaches to inform your work. We'll begin our summit today with a discussion on the past, present, and future of health equity and the role of the health policy community in affecting change. I invite you to be an engaged participant in this discussion with our panelists and to deepen your thinking on the ways that health and equity come together. You can join today's conversations on Twitter at the hashtag AHPSummit21 or follow us at All Health Policy. Materials for this event will be located on the left-hand side of your screen within the Agenda tab. Please select this session to view details and extended speaker biographies. And now, I am pleased to introduce Mr. Daniel Dawes for today's keynote discussion to kick off our Health Equity Summit. A widely respected scholar, researcher, educator, and leader in the health equity, health reform, and mental health movements, Daniel Dawes is Executive Director of the Satcher Health Leadership Institute at the Morehouse School of Medicine in Atlanta, Georgia, and a professor of health law, policy, and management. He's also the co-founder of the Health Equity Leadership and Exchange Network, or HELEN, which is a nationwide network of over 2,000 governmental and non-governmental leaders, researchers, and scholars focused on bolstering leadership and the exchange of research, information, and solutions to advance evidence-based, health equity-focused policies and programs. Among his many achievements, Daniel was an instrumental figure in shaping and enacting the Mental Health Parity Act, Genetic Information Non-Discrimination Act, the Americans with Disabilities Act Amendments Act, and the Affordable Care Act, as well as many other federal policies. And he is the author of thought-provoking books, such as 150 Years of Obamacare, and more recently, The Political Determinants of Health. So Daniel, we are so pleased to have you join us today.
Well, it's great to be with you, Sarah, and thanks to the Alliance for Health Policy for the opportunity to join you.
Well, thank you so much. And so I've been reflecting a lot these last some years on what drove me to get into health policy. I want to start by asking you that question. What drove you to get into health policy, and what does health equity mean to you?
You know, that's a great question, because I think a lot of individuals enter health policy for different reasons, right? A variety of reasons, and in response to different stimuli. So for me, I would say that health policy, and to the greater extent, health equity, has always been a key component of my own life. Having family in such areas as Florida, in Miami, Florida, all the way to rural Nebraska, in Deschler, Nebraska, growing up my siblings and I were exposed to poor health outcomes and the difficulty, right, that many of our family members, both in urban and rural settings, had in accessing quality healthcare. And those challenges stuck with me throughout the years. So, when I entered law school, I, I began learning more about the role that legal and policy decisions at the top have on people near the bottom. And it all just clicked for me. It's at that point that I realized that one of the most effective ways that we can help people that I care so deeply about was to get involved in health policy. And that's because I recognize that only policy can fix what policy has created in the first place and has been perpetuating and exacerbating in our communities at that grassroots level for years on end, right? And now that I have, children of my own, I'm even more invigorated to continue to leverage my position and advocate for the changes that we so desperately need in health policy. So if I want my own family to experience a better tomorrow, a healthier, more inclusive and equitable future, well, it starts with me, all of us really, doing our part today.
Thank you so much, Daniel. And you've certainly spent your entire career on this. So I want to ask for your perspective on, the past year and a half, really, we've had a much broader group of health policy stakeholders really not just talking about health equity, but making investments in health equity. Whereas it seems to me in the past, even though we've known about this, conversations have been much more siloed. It was like, we're going to have one thing on health disparities, or maybe we would talk about social determinants of health. So I want to ask you, what do you think is the significance of the conversational shift to health equity? Do you think there's truly a greater recognition of health equity as a more systemic issue that really encompasses and acknowledges both the historical legacy, the current impact of, things like systemic and structural racism, which have entered the lexicon, right, in a much more robust way, even though, of course, it's always existed. So, what do you think is the significance of this shift now?
I think it is long overdue. 1985 was when the World Health Organization really introduced the concept of health equity. And then you saw in 2008 another attempt by the Commission on the Social Determinants of Health at the World Health Organization to really get us to think about what has been, driving many of these inequities. And they coined the term the social determinants of health. And I know, for decades, many health policy leaders were on the fence when it came to these concepts. And, quite frankly, even for me, having worked in the House and in the Senate, working on some of the landmark policies that you talked about, it was extremely frustrating because, when you're trying to apply an equity lens, you sometimes come up against, opposition to utilizing that lens, right? And so for me, it is invigorating for folks to now accept and embrace that there are these systemic inequities, right? They are systemic, they are structural, they are, embedded, they're concretized in our systems. And that's what's keeping us from being able to realize this audacious goal. And for me personally, health equity boils down to meeting people where they are. And by that, I mean, we have to give people the care that they need, right? When and where they need it, and in the amount that they need so that they can reach their own specific optimal level of care. I think, all too often, people incorrectly think, they think of or strive for equality in health. And that would be the notion of treating everyone equally. And that simply will not do. And I know folks are probably listening and saying, really, equality won't do? Well, no, because it fails to take into consideration this notion of all of the historical and systemic harms that marginalized communities have endured and continue to endure, quite frankly. And that is why health equity is rooted in evening the playing field by taking those historic harms, all of the injustices from the past, into consideration for each individual. And I think we cannot expect population groups that have had to fight for even the most basic levels of care and even respect since the birth of our nation to have the same health outcomes as more privileged groups without first taking that history into consideration. For me, health equity is an approach to healthcare and even overall health that encompasses the entire health system. Our health is not tied solely to our own individual actions. The systems that we live in play a significant part. The same must be said for our approaches to achieving a more healthy tomorrow, though.
Thank you for that, Daniel. And look, I think we shouldn't beat around the bush here. I mean, the conversation around race and the history of racism, racial inequity is still a very uncomfortable conversation for a lot of people to have. And I want to, and there can be a temptation sometimes or a tendency to say, well, the past is in the past. So like what I want to ask you is, can you get specific, if you would, around, are there some specific examples that really demonstrate to you how this legacy has affected present day inequities and how is that materially impacting health outcomes today?
Oh my goodness, absolutely. I mean, we see this, manifested through policies from over 400 years, 300 years, 200 years, 100 years, all the way to contemporary history. You can see the effects on these communities. And, certainly the fact that we're living in some interesting and trying times during this dark and historical moment, really is an understatement. I would dare say that Americans are starting to wake up and realize that there is an interplay, happening between our history and the barriers that we faced in the past, which continue to, the present and modern day. So I want to take us back, if you don't mind, Sarah, 400 years. And I'm not going to start at 1619. I'm going to start at 1641. And I'm intentionally doing that because this was the time when, the business interests, slave owners had feared that the abolitionists were making headway in showing how immoral this institution of enslaving people really was. And so in order to sustain their business model, they created a law called the Bodies of Liberties statute. And Massachusetts negotiated it, they passed it, they eventually implemented and enforced this law. And you see the other colonies following suit. So Connecticut and New York and others really embraced that as a template, that law. But what's interesting is that, it was amended to include the children of these enslaved women as being slaves for the rest of their life. They concretized that again in the structures. But as if that were not enough to keep a group of Black and Indigenous populations down, what I think is quite fascinating is that there was then a further attempt to create policies explicitly prohibiting these marginalized populations from being able to address their social determinants of health. They were prohibited by law from raising their own food, from earning their own money, from being educated, from learning to read and write. They were also limited in terms of their movement. They weren't allowed to go out beyond a certain mile radius. If they wanted to go out and exercise or walk or whatnot, they had to have passes or carry lanterns if they were going out in the evening time. I mean, it's a fascinating history that, as we think about these drivers, and we've now been able to determine that the social determinants of health play an outsized role in our health status, right? And in our life expectancy. Well, it's interesting to know that it started from then, and these policies were then recycled from one generation to the next, from one century into the next. We saw into the 1800s how, Jim Crow reared its ugly head with a vengeance. And during that time, we saw the proliferation of laws at all levels of our government, all policies that again were intended to make it even more difficult for newly freed people, right? These formerly enslaved Black people and other minoritized and marginalized communities from being able to address their social needs, their social determinants of health in particular. And even when there was an attempt now to go beyond these explicitly racist policies, right? When we got into the early 1900s, what you saw was the creativity of racist policies that went from facially discriminatory policies to what we call facially neutral policies. So they didn't explicitly discriminate against a certain population group, right, based on race or ethnicity or national origin or another what we call protected class today. But they essentially, once they were created in such a way to exclude certain population groups so that those social and economic policies in the early 1900s would not benefit these groups, right? We saw, for instance, an effort by the Franklin D. Roosevelt administration to enact a law right after World War I called the Homeowners Loan Corporation Act that said we want to authorize property appraisers to go out into over 200 cities in America. And we want them to grade these neighborhoods in the cities. And they graded them from an A, B, C, or D and aligned them with a certain color code. So your A communities were your affluent white communities. Those were your green communities. Your B communities were your middle class white communities. Those were your blue communities. Your C communities were your quote unquote undesirable immigrant communities. And lastly, your D communities were your hazardous communities, right? These were your predominantly African American communities, as they were determined to be hazardous at the time. And that's where we get the concept of redlining from. Well, what's interesting about policy is that it was a policy that created that study. The study then, in turn, led to the development of additional policies at the federal level that determined whether to give certain communities, whether yellow or red line, access to home mortgage loans, right? So whether VA loans or FHA loans, et cetera. And what the federal government did essentially was to further starve these communities, these Black and brown communities, of the resources that they needed, not only to survive, but to thrive. And today, afterwards, we also saw additional policies, what we call facially neutral policies again. You know, when you think about today, when you go into Black and brown communities in the United States, you may have noticed a major highway that splits these communities in half, right? Cutting right through the neighborhood. If you live in New York City, you may have noticed a disproportionate number of bus depots that were located in Harlem, a predominantly Black and brown community in Manhattan. You may have noticed railroad tracks disproportionately cutting Black and brown communities in the Midwest and in other areas of our country. Again, we must think about how the structural conditions that these people are living in today were actually created in the first place. And when we tie it to these social determinants, it's clear from a public health standpoint that yes, there's no wonder why, you know, Black and brown communities, for instance, have higher rates of asthma. They're breathing in the most polluted air, right? Owing to these infrastructure. It's no wonder that we see higher rates of diabetes and cancer and heart disease, again, owing to these pollutants in the atmosphere. Again, we must complete the equation and go further upstream to the political determinants of health that have really instigated these social and environmental and healthcare determinants that folks are struggling with today in our society.
Wow, thank you for really leading us through that history and really emphasizing the generational impacts and the structural impacts. It's not as simple as just getting up and taking a walk sometimes to improve your health. It's far beyond that. And I want to ask you, what do you think now? Are there existing current pervasive policies or practices that are, you know, whether intentionally or unintentionally, kind of perpetuating these inequities at the health system level?
Oh my gosh. Yeah.
What we do going forward.
You know, great question. So the answer is absolutely. There are a host of current policies. You know, when we think about health coverage, for instance, it's built on this chassis of economic inequality that was perpetuated by generations of economically discriminated folks, right, based on race, essentially. And now in a crisis, in this quadruple pandemic that we're in, you know, we see inequities that are perpetuating themselves with low income or uninsured individuals, right? Starting off having less access to care. There's also the issue of differential payments for care through public and private Medicare and Medicaid. One of the things that I know we were talking about, Sarah, before we got on was this notion of the provider relief fund, right? Which, you know, is making it easier to get Medicare money out to out the door to hospitals than Medicaid, you know? And which is interesting considering that these hospitals are primarily serving lower income and uninsured individuals. So there are a host of these policies, and two additional ones that I'll quickly bring up if we have time is the idea of data too, right? Data is so critical; it's foundational to a lot of these programs that we've tried for years to institute. And early on in the pandemic, over the last year and a half, my colleagues and I at the Satcher Health Leadership Institute were extremely worried based on the evidence of past pandemics that struck the United States that we would see a similar result again with COVID-19. And we went all the way back looking at data from 1793 all the way up until today. And one of the things that we found was that it's always the same groups of people who are on the downside of advantage and opportunity that are most negatively impacted during these pandemics. And it's namely racial and ethnic minorities, lower socioeconomic status whites, people with disabilities, and immigrants, really, that suffer the worst. And we kept thinking to ourselves, well, what is the one thing that we've noticed that has been so difficult to move this needle of health equity forward during these very difficult, very challenging times, right? Scary times. And it dawned on us that data was a real problem, that a lot of times we weren't able to get access to the data and comprehensive data in as close to real time as possible. And that it wasn't until the pandemic subsided, right? Once they had overcome that issue, that they were able to access the data, conduct the research, crunch the numbers, and again, recognize what was happening. So we thought, well, surely in 2020, having gone through now and having published in the Academy over 7,000 peer-reviewed journal articles, looking at these issues of health inequities, with the technological capabilities that we have, understanding the intricacies with data collection and reporting, surely we could correct that one particular issue. Oh my gosh, Sarah, much more difficult than we thought, right?
Much more difficult, yeah.
From the front end all the way to the back end of this process, we ran up against one barrier after another. And we thought, well, no wonder we've never been able to realize an equitable response during pandemics, because this has never changed. We have this issue with trying to standardize data.
And we're still talking about it. In fact, we're going to have a panel on it. But unfortunately, we're starting to run toward the end of our time, and I really want to get to how do we move towards structural inequity? How do we move forward? And I'm curious. You mentioned a couple of things. Are there three tangible things that we can get, that institutions, organizations, policymakers can really put into place to begin to embed equity into policy?
Yeah, great question. So let's end with a look into the future, right? And I think the most succinct way of thinking about structural equity is to frame it around the end goal, the goal of sustainability. So once we shift our way of thinking and addressing problems from the viewpoint of just putting out the immediate fire, to instead making sure that there are no more fires in the future, then I think we'll begin to build a more sustainable model for health equity. An interesting thing about that future is that the only way you build a sustainable model is by impacting the structural inequities that are concretized in the system itself, into the system, right, itself. And here's an example. So when I envision a more equitable future, anytime there's a global pandemic or a major crisis that might require a vaccine, for instance, I don't want us to continue to have that conversation about racial disparities in the rollout. What does it look like to avoid that to begin with, right? Well, I think we need to address the systemic and the structural inequities in the process now. We need to diversify clinical trials. We need to engage communities of color early on into this process, and often, right, during the scientific process, working harder than we have ever to develop meaningful relationships with these communities and actually invest the time that it's going to take to realize that. And then I think we also need to make sure that diverse perspectives are heard from during that communication phase. So those are three quick examples that I can think of how we could impact structural inequities now so that we have a sustainable model for health equity tomorrow. And even still, while I'm a self-admitted future-looking visionary, I understand and appreciate the need to address problems in the short term as well. So when we're thinking about the structural inequities that we could be fixing right now, I think one of the best examples is shoring up the health equity pipeline. As you know, I work at a historically Black medical school, so I'm acutely aware of the need to diversify the healthcare workforce. And we know that, when your provider looks or talks like you, individuals are more likely to engage in our healthcare system. That is true if we are talking about your doctor, your nurse, your physician assistant, or really any professional, any clinician that's within our healthcare system. And when you really think about it, Sarah, it makes sense that there would be an increased comfort level and trust when interacting with individuals who share commonalities with you. So I'm arguing that we could and should extend that logic to the broader health equity pipeline, exposing more students of diverse backgrounds to the possibilities of doing health policy work, or introducing diverse undergraduates or even high school students to career paths that are centered in public health, which could have a similar outcome, I would actually argue. And if we want to really get more people attuned to the needs of health equity and plugged into the health policy pipeline, we'll see sustainable structural change. And we're going to see it almost immediately, I would argue. And lastly, to that end, because of the great opportunities that, like this one, to speak with you, every now and then I get to speak to young people and with young people, and specifically people of color. And they ask me for advice without fail. If a person asks me my career, how my career brought me to where I am, I always end it with the same refrain. So why not you too? Why not you too? That is the single best piece of advice that I ever received, and I try to pass it on as well. It doesn't matter what your background is, and it does not matter how old you are. Just by you being you, I think it brings a much needed and refreshing perspective to whatever health equity conversation is happening, so long as you speak up and engage. So please, we need more advocates. And I think you should be one.
Wow, well, that is so inspiring. Why not you too? And get there in the room where it happens, right? That is amazing. Thank you, Daniel. Well, unfortunately, that's all the time we have today, but I hope this is not the last conversation we have. This has been tremendously inspiring and informative. Thank you. I want to thank you so much for joining us today and offering your insights.
My pleasure. And thank you again to you and the Alliance for hosting this really important discussion. Thank you.
Absolutely. And I hope folks should stay tuned, because we are going to, in fact, touch on many of the issues that you raised around data, diversity in clinical trials, as well as how to reach more diverse communities. So so it's fantastic. To our audience, we would love to hear from you. So take a moment to fill out our evaluation, open the survey module on the left of your screen, and help us plan our future events. And a recording of this webinar and all materials will be available for you to view at any time in the Eventia platform. So join us for our next summit session in a few minutes towards better health for all, hearing from underrepresented voices in the health equity dialogue. And make sure you join, click the next event under Live Now in the right sidebar to join the next session. So I'm not really good at tech, but I assure you, if you click that, you will get to the next session. Daniel Dawes, thank you so much for joining us today.